thank you. I have no disclosures. As many of you know, I'm from Ghana. I came here for college. In Ghana, we have a lot of traditions that are customs. One of them is when you go to someone's home, in order to make you feel welcome, they will give you a seat, they will give you water to quench your thirst, they would give you food to eat, and they will ask how your journey was and where you're coming from is. And I can tell you that over the past almost like 6 hours that I've been here, you have done that for me without even knowing you've engaged in this custom one way or the other. You've invited me into your homes, your spaces. You've given me a seat, you've given me water and some alcoholic beverages, which I've been very appreciative for to quench my thirst. You've broken bread with me, which is so meaningful in my culture. And you've asked how my journey has been and how things are where I'm coming from. And I can tell you that I bring you very warm greetings from Michigan. There's so many people who admire you equally, friends and colleagues, and from the land of Go Blue. I didn't know this phrase until I got there, and it seems as if every single speaker ends with Go Blue. So I'll start that off at Go Blue. And just again, feeling very warm and welcome. So May 2nd, 2021, I got this WhatsApp message from a lady who had been my senior in high school. I went to an all-girls boarding school in a different region from where I grew up in Ghana. Regions are very similar to states, but smaller, just because Ghana is smaller than when you think about the US. So it was in a different region. She had been my senior. She had moved to the US. She's highly educated. I will say she's middle income. She lives here with her immediate family, but her extended family is all in Ghana. And I provide that context to say that she has some means. She has some education so that she can understand what's going on. And then she can also provide for her extended family that's in Ghana, which when you think about most of the people living in Ghana, that is not the case, but just to set the context for you. I hadn't spoken to this lady in over 10 years. So she reaches out, and I'm just going to read some aspects of this text message. So she said, I have a few questions regarding my dad. My dad has had diverticulitis for a while now, and his hemoglobin started dropping. They've tried using iron supplementation. There's just a continuous drop. When I talked to her subsequently, she said this was an 80-year-old man who had served in the army, was highly functional, and within the span of 2 weeks had gone from walking to using a wheelchair because he kept on falling. They had been a bit alarmed. Her brother's friend managed to do a CT scan and get some lab tests done. His hemoglobin was 6, and she attached a copy of his CT scan, and I got permission from her to share this information. She actually wanted me to include the name and everything, but so I looked at the CT scan. It said there were multiple diverticuli, pancolonic distribution. There was this infiltrating mass that was involved in the ascending colon. There was some stranding around this mass. They measured it at 7x4x5 with luminal narrowing. And this is a scan done in Ghana read by the radiologist down there. She attached a colonoscopy report that they had a few weeks later on. The colonoscopy noted hemorrhoids with diverticular disease. They said the hepatic flexure was normal, ascending colon was normal, and the cecum was normal. The CEA was 14.4, and I've included the reference range that they used there. She went on to say, it turns out there was no mass as the CT suggested. I am just a bit concerned because of the discrepancy, but what do I know? She talked to a friend, they said they should reach out to me. And I can tell you that this is just about one of multiple text messages I get from colleagues who have known me, who are many abroad, and then trying to advocate for their loved ones back in Ghana. So for the learners in the audience, I'm just going to review a couple of statistics around colorectal cancer when it comes to the global stage. So about 1 million people are diagnosed worldwide with this. It's the second most commonly diagnosed cancer in women and the third most commonly diagnosed in men. Not surprisingly, we're expecting this shift over time, such that we're going to see a little bit more of this in sub-Saharan African countries, so low middle income countries. By 2030, we're expecting 1.1 million deaths annually from colorectal cancer. It's going to be huge in sub-Saharan Africa, and the morbidity and mortality related to that is going to be highest in that region too. We have very limited data from sub-Saharan Africa for a variety of reasons. I will highlight a few of those subsequently in my talk. But we do have some descriptive observation type studies from a few countries. I will give some examples from Kenya and then from Ghana. So in Kenya, this particular figure, I've summarized the key takeaways in the box below that. But in general, compared to the US, they are seeing an uptrend in colorectal cancers. The distribution is mostly like left rectal cancers compared to the US, where we see colon cancers. And then if you look at the age distribution, so 20% of this population were cases under 40 years compared to the US, where it's 3 to 7%. Granted, this data is from 2019, and we know we've been seeing increasing rates of rectal cancers in younger populations now. And so I wonder how it's going to look like if we repeated this study now looking at our data here. The range that they had in this population was 19 to 38, with the youngest being 14 years old. And I can tell you that that has been replicated in other sub-Saharan African countries. The youngest age is 10 years, with no family history and no genetic predisposition, which raises very interesting questions when you think about that space. This is another study that was also done from Kenya. They looked about 300 patients at 2 major hospitals between 2005 to 2009. They were really interested in mortality, and then they looked also at recurrence rates. But this is basically to show that, as we know, even here in the US, the early stage, the earlier you present, the better the outcomes compared to if you present later. They follow these patients for 60 months, but you can see stage by stage in terms of the differences there. This is data from Ghana. And what I've done is basically plot side by side in terms of the 5-year survival rates, depending on when you present. The US is to the right of the screen and Ghana is to the left. In Ghana, 60% of patients are presenting with stage 4 disease. Compared to the US here, 40% of our patients present with stage 1. So then you can immediately see the disparities and the implications of that. Now, this is the USPSTF colorectal cancer screening guidelines. This was from 2016. And I like this just because it's a nice picture. It makes it very interesting. I'm more of a like led by figures or images instead of words. So having it displayed this way makes it easier. But in general, we have those stool-based tests, and then we have the endoscopic approaches to it. The stool-based tests typically are picking up on blood in stool. And because they are not as sensitive, we have to do it more frequently compared to when we do endoscopies. And this is generally what we recommend here in the US. I can tell you that from a public health standpoint, I get why we have different options for how we do colorectal cancer screening here, even in the US, especially when you think about access, the cost, insurance, disadvantaged groups not having easy access to an endoscopy facility. But we do know that for a preventative standpoint, doing a scope is far better than a stool-based test. Because by the time we detect blood in the stool, someone has probably an advanced polyp, already has cancer. And some of the toughest conversations I have in my clinic are, usually it's a Black patient who has had their Cologuard tests faithfully for many years. And then finally the test comes back positive, they get a scope and a subsequent staging, and they have metastatic cancer. And they're sitting across the room from me, and their question, it always comes up. Did I do something wrong? or did I get inferior care because I was Black? And some of these patients were never given the option of a colonoscopy. So I'll just put it out there that I do struggle with some of our approaches, even from a public health standpoint here in the US, and then how we determine which particular screening methodology we push and in which populations, because sometimes those are based on assumptions that we make about the care or access or options that people would choose. But this is the colorectal cancer screening guidelines that we have here in the US. This is a guideline in Ghana. So a lot of sub-Saharan African countries actually don't have any screening guidelines, but Ghana does. This is something that was developed by their physician and college group and then the Ministry of Health. If you go to their website, it is there along with a bunch of other screening guidelines. So they recommend if you're between 50 to 70 years old, you should get a fecal occult blood test. If that is positive, you should go on and get an endoscopic evaluation of some sort. Now, it's interesting because if you look at life expectancy in Ghana, in 2000, it was 57 years old. In 2019, it was moved up to 69. So we have a screening guideline that sets the age range as 50 to 70, but the life expectancy for the average Ghanaian is 69. And this whole guideline was taken wholesale from what we have in high income countries. So not even applying the basic in terms of what is your life expectancy of your population in creating this guideline, which I think is an overall problem when you think about what we do in global health, because a lot of times we go into those spaces and we are taking things that have been applied or used in high income places that we have a lot of evidence to back, and then we try and apply them wholesale in spaces where they might not have the resources or might not even meet the age criteria for that. So this is definitely a classic example. So between when COVID happened, but my team was trying to do some a needs assessment and also do interview surveys and semi-structured interviews of physicians in Ghana who take care of colorectal patients or would see colorectal cancers, and then also interviewing patients. And we did this at Kumasi, which is the second largest urban city in Ghana. And they have the second largest teaching hospital, which takes care of the entire population of Ghana and then also neighboring countries. So they have folks who come there for their care. And we did, this is the survey results, looking at physicians, either surgeons, general surgeons, or GI providers. And we asked them, are you aware of the screening guidelines that the Ministry of Health has? And I can tell you out of the group, less than 5% of them were even aware that there was a screening guidelines. No one above the age of 50 had gotten a scope or screen at all, even though they were providers and they were doing a lot, seeing these patients come through. So none of them had gotten tested. We were actually having to send them the link to the website and printing out the pages for them because they had no idea they even had this policy. We asked them, okay, imagine you had an asymptomatic average risk patient who was showing up at your clinic, and we also had oncologists in this group, but was showing up in your clinic or had been referred to you. What would be the reasons why you wouldn't recommend fecal occult blood testing? This is a subsequent question in the survey because we asked them, would they recommend fecal occult blood testing? And if they said no, this was the next thing they would have to respond to. And overwhelmingly, the response was they didn't have the equipment or the facility. Some of them had never seen a fecal occult blood test card before. And then they lacked training in the procedure. They just didn't know how to do it. And then there was this poor patient compliance. But you can see how the data is spread. So we asked, what are the barriers? As a physician who's in this space, who's seeing patients coming in with advanced stage cancers and others, why aren't we doing colorectal cancer screening? What are the issues? And we looked at it from a patient level barriers and a systems level barriers, really asking the providers their thoughts about it. And you can see on the patient level side, they were like, patients are just unaware of screening or might not even think that colorectal cancer is a serious health threat. And I think it's a reflection of their own thought process regarding this. They themselves did not even see this as such an important issue. And then on the system level barriers, I mean, everything. The dark blue is that, this was a major barrier. Screening costs are too much, or insurance doesn't cover it. The primary care physicians are not recommending it. There's shortage of trained providers. They don't have providers to do the fecal occult blood test or even the subsequent endoscopy if it got to that. To give you some indication of the issue, in Ghana, we have 11 GI providers who provide care for 30 million people. So that just gives you in terms of that. The general surgeons help out with scopes, but still, that means that even if you found someone who had a positive fecal occult blood test, and then the government says they should get an endoscopy, they don't have the resources to do that. And then the cost is too much. And this was very interesting, sitting with the GI providers and again, as part of the needs assessment, trying to understand what they meant by cost, because that's not necessarily something I think about as much when I'm with my patients. So Ghana, we have a national health insurance scheme or levy. When you buy something, taxes are taken out of that. A portion of your taxes are then sent into this national fund or bucket, which is supposed to help provide care for patients who can't afford it. And there are specific things that are included under that coverage because they can't cover everything. Under that, breast cancer. If you look at the cancers, breast cancer is covered. Breast cancer, they'll pay for your screening, your treatment, your hospital care, everything will be paid for. Colorectal cancer is not there. Pediatric cancers are not there. A lot of the cancers that you think should be under this are not there. And so because of that, everything colorectal cancer screening related is paid out of pocket. So if a patient can get to a center where they can get a colonoscopy done, and so that's considering transportation issues, they have to leave work and everything. If they work on the farm, that's a day off that they can't take care of their family. They have to pay for the prep out of pocket. They bring their own sedation. You can get it from a pharmacy because it's not kept in the hospital or wherever. So you go to a local pharmacy or chemist, they call it chemist shops. And then you buy your prep and you bring it. And then you pay for the procedure. When they do the scope, if they take out, and the GI providers will tell you that they don't feel comfortable taking out polyps. So they do biopsies of polyps. But if they do the biopsy, you have to pay for the biopsy procedure, and then you have to pay for the pathology review. And the GI, one of the GI doctors said, if it wasn't clear before the patient went to sleep, if they could pay for the pathology review, sometimes they would wake the patient, they would pull out the scope, wake the patient up and ask, we saw XYZ. We want to do a biopsy of XYZ. Can you pay for it? Can your family pay for it? And if not, then nothing is done. So at that point, no polyp is removed, no biopsy of a potential cancer is done, and we don't have any data. So you can see how that compounds a data collection issue. So even if they got to get in a scope, there are limitations or barriers there such that they can't get the information needed. We went to the pathologist. They have information there, but they only have information for the people whose samples get there and actually paid for. And they won't begin reviewing the samples until the payment is complete because it's an out-of-pocket process. If they can't take out the polyp or they decide, then instead of making the patient pay for pathology costs, they could say, this is a big polyp. Instead of you paying this cost, why don't we have you raise money so you see a surgeon, and the surgeon does the surgery instead. And if you can't pay money, then we won't even get a CT scan because access to a CT scan is an issue. So all the things that we think are important when we see a cancer patient in terms of our staging, they are going to factor in costs and ability to pay for different aspects and then skip things. I sat in a tumor board and they were presenting, one of the residents was presenting a case of a patient who came in, blood in their stool. On digital rectal exam, they could feel a mass. The patient can't pay for the pathology. They're going to assume it's a rectal cancer, even though it could be an anal squamous cancer, but they're going to assume it's that. The patient can't pay for CT scan. One of the surgeons is like, okay, why don't we go palpate their spine, tap on their rib cage, and then see if there's any pain there, because if there's pain, then they might have bony mets. If there's no pain, then probably there are no bony mets. We'll get an x-ray of their lungs, and then if we can see something on the x-ray, then that tells us they might have metastatic disease. Nothing on the x-ray, then, and then we'll go ahead and do a surgery. This is another patient, a classmate of mine, also in high school. This is from December 10, 2020. She sends me this picture, so I hadn't spoken to her in over 15 years or so. She's also here in the US, middle income, well-to-do. Family lives back in Ghana. Her mother had been having blood in her stool, also fallen, very weak all the time. She had had a colonoscopy done, which my friend had paid for. They noted a tumor at the cecum. They said there were multiple polyps throughout the colon, and there was a concern for a polyposis syndrome. So this is a representative picture she sent me. And I was like, I see maybe some diverticular disease. I see something maybe in the cecum, but where are the other polyps? How are they coming up with this conclusion of the polyposis syndrome? So I asked her to, if she can, get another colonoscopy at a different location by someone who might have more experience. She had the means, so she went ahead to do that. There's a report that she sent me. They found a 2 by 2 centimeter polyp that was 30 centimeters from the anal verge. So I'll put that maybe in the left colon, somewhere there. There was a less than 1 centimeter polyp that they also noted 30 centimeters for the anal verge. The transverse colon was not visualized, but they were able to get into the ascending colon and then found a 2 by 2 centimeter polyp there, and the cecum was normal. They took biopsies, and they put the biopsies all on a single cassette. So if you do any scopes, we recommend you put them in separate ones, because then you want to know where your disease is. So they put it all in the same cassette. And again, we are paying out of pocket. All of this we are paying, my friend is paying out of pocket. One of the specimens comes up being adenomatous polyp with low-grade dysplasia. This individual they had seen who, since they gave a surgical recommendation, probably is a general surgeon, but could be a GI provider, recommended a total abdominal colectomy with a permanent end ileostomy. My friend's question was, if this was my mother seeing me here in the US, what would I do? Her mother was refusing an end ileostomy. It's like she didn't want that. From a stigma standpoint, she didn't want to live. She'd rather die than have that. I'm looking at this report. I'm like, why? I mean, this doesn't count as a polyposis. I'm confused about what they are seeing and why the transverse colon was not visualized. I'm confused also about there's nothing in the rectum. So why are we giving her an end ileostomy? Why can't we hook her ileum to her rectum up, even if we need to take out her whole colon? So then I suggest, if she was here, I would want more information. I would want her scoped again. I would want maybe GI could do an EMR. There's so many things that I still don't know. But I'm talking to someone with a family member in Ghana with a whole bunch of issues. And then each time they pay is money that they have to like come up with. Her mom had lost trust in the system. So her mom was like, she's not getting any care and she wants another opinion abroad. So her friend checked with one academic center here in the US. My friend, sorry, checked with an academic center here in the US. Not Michigan and not Stanford, but and they said it was $75,000 if she came for a segmental colectomy here in the US. So not even like total abdominal colectomy. So if she came for a segmental colectomy, that's $75,000 prepayment. So before they even got here, we had to like come up with $75,000. And if you know the healthcare system, yes, this is definitely cheap, but at the same time, India will be $10,000. And my friend was like, she has young kids, a whole bunch of other things, but she can do 10,000. She can do 75,000. And you can see my reaction there. I was just like, I think insane, but knowing our systems, definitely the price point makes sense. So clearly a lot of barriers. We have healthcare providers, we have patients who don't know that the screening is needed. Colorectal cancer is an issue. We have an access issue because folks are coming from very far off and then trying to get to places where they can get some tests done. No fecal cord blood testing is happening in any of the communities or in the villages. So if they have a problem, they're trying to get to a health center, which is usually going to be in one of the biggest cities. I went over the cost issues, which are huge when you think about people paying out of pocket, and they don't even have providers to do the fecal cord, to do the endoscopy stuff. And then if you think about pathologists too, one of the sub-Saharan African countries has one pathologist to 1 million people. So if you look at those capacity numbers, it's just insane. And all of this is not covered by the NIHS, which is our health insurance system. And talking to people in government, they said it's data. They don't have data to justify spending money on that. Compared to breast cancer, where there's been a lot of lobbying that has happened internationally, a lot of that has been driven by US and other high-income countries that have made this a priority here in the US, but also have gone out there and invested money. The amount of money that is out there in low-income countries around breast cancer screening is huge. They have vans that go around to villages and then do the mammograms in the car. You can show up and get all your chemotherapy, your surgeries, everything covered because there's been money poured into it. We have the data to back it up. The Ministry of Health said, if you show us the data to justify that colorectal cancer is an issue, we will look into sort of investing into the space. Now, I have to tell you, when I left Ghana, my whole thing was I wanted to become a physician and then surgeon. My whole thing was I wanted to go back and then work there. I wanted to physically work there, spend my entire time there. Life happens. I ended up having 2 kids. And that has complicated things in so many ways because I have a child with a chronic illness who needs access to medical care. So that whole plan has changed. I'm now here in the US trying to find ways to help my people who have, I feel like they need more healthcare professionals. Clearly, as a colorectal surgeon, I love taking care of my patients here, but clearly there's a huge need there. There's not a single colorectal surgeon in Ghana or the entire West Africa. So I feel that tension. When I became a faculty at Michigan, Michigan has given me so much opportunities to go down and do this work and finally get into that space. And I can say, like many folks coming from high-income countries, I did have that savior mentality, and I will confess to that. I went down thinking, now we're going to fix this. I'm here, I'm a colorectal surgeon. I understand the issues. I have the training. I have the public health degree, which I got because I wanted to help solve some of these issues. And I went down and just doing the needs assessment, just talking to people. I was like, this is not a simple fix as let's bring one GI doctor and a colorectal surgeon down here and it will fix this. This is huge. This is system level issues. This is policy issues. This is like, the scale of this is much bigger. And I was overwhelmed. And I have to say, I was so disappointed because I felt I had finally gotten the skills and I couldn't use it. I wasn't going to be of any help. And around this time, COVID happened, which then you can imagine in a healthcare system that is already stressed, the impact of that on access to care and all of that. And it was a really tough time for me in general. Around this time, I was fortunate to connect with a multidisciplinary team at Michigan consisting of GI physicians, radiation oncology people, data science experts, statisticians, bioinformatics folks who were sort of tackling or grappling with similar issues with their local partner, Aga Khan University in Kenya, around the cancer, the increase in numbers that they were seeing there and what to do about it. Around this time too, the NIH came out with an RFA around data science initiative for Africa specifically. So there was renewed interest in coming up with ideas, innovative ideas to how do we approach this. We all agreed that it didn't make sense to take wholesale guidelines, principles, approaches that we use here in the US, and then take that to developing countries. Whatever we did needed to be context specific, but definitely thinking outside the box. So how do we engage in screening? How do we address this issue where there are not enough providers to actually do it? We don't have the resources to train a ton of providers, both from the GI, surgical, but also in terms of pathology standpoint. So there's all these providers that we don't have. And looking at the literature, there's all this work that has been done around artificial intelligence and machine learning around early detection of colorectal cancer in high-income countries. And I'm going to share some of that data with you, but we thought it would be awesome if we could apply some of that knowledge within these contexts, using a very different approach to the traditional ways we have gone about doing colorectal cancer screening. So even here in high-income countries, we've come up with all these different ways of doing less invasive testing to come up with the answers that we want. So this is like the newborn baby screen where you take a blood sample, and from that you're able to rule out a ton of different genetic abnormalities. Now you could actually get a non-invasive prenatal testing your first trimester, where they draw blood from the mother, and from the blood, they are able to pick up on these chromosomal abnormalities in the baby. And you can actually get to know the sex of your baby just from a blood test of the mother. And if you think about that, that's insane. Like how we have made such great advancements, such that you don't have to wait until I think it's your second trimester, where they have to do an ultrasound and try so hard to see a feature on the baby that would tell them is it a boy or a girl. Now you could do a blood test and have all of that information. Now, blood is something we call, it falls under this larger umbrella we call liquid biopsies. So liquid biopsy would be a fluid sample. So urine, spinal fluid is also a liquid biopsy. We have been using liquid biopsies here in the US, circulating DNA for tumors, cancer tumors and stuff. You could get fragments of DNA or RNA in blood samples. You could get vesicles that have a tumor within them. You could actually get whole cancer cells in the blood samples. And again, that changes the whole thing because you don't have to go looking and seeing a cancer. You could do a blood test and then be able to tease apart just from the blood cells what's going on. So this is something that's already being used here in the US, so using blood as a means. And folks have been looking at which components, like what do you really need in the blood in order to detect or make these predictions. So this is where a lot of people have been drawn to CBC specifically. So CBC is interesting because if you know a lot of our colorectal cancer patients, about 60% of them are going to present and part of their history is going to be blood in my stool. So they notice some sort of blood loss. And in 88% of patients, they will have at least one abnormality on their blood test. So there's a lot of work around using CBC in prediction models or tools as a diagnostic way of picking up colorectal cancers. So not using a stool-based test, not using an endoscopy, using a blood test. So this study did a systematic review of about 50 published articles that have used CBC within a prediction model. And from that, they found that in general, all of these studies had some things in common. Patients who had colorectal cancer were more likely to have this sort of like changes compared to a healthy patient. Higher platelet level, white blood cell count, LCW, and then they have lower RBC, hemoglobin, and MCV. But they found that that wasn't enough to make a strong enough prediction. You know, the prediction models for some of these papers were not strong enough. So the recommendation was for additional studies. This is another test where they're using machine learning to sort of evaluate or create like a better prediction model. What I like about this study was they're trying to figure out, could you detect colorectal cancer before someone came to clinical attention? And this is here in the US. So this is using the Kaiser Permanente Northwest Regions Tumor Registry. I'm guessing you're familiar with the Kaiser Permanente system, but they have an awesome way of tracking patients longitudinally because most patients get their care at those centers, but they looked at roughly about 1,000 patients who had colorectal cancer and had gotten CBCs done, and then they had about 9,000 people as controls. But they looked at from your time of diagnosis, 24 months after that, all the lab tests that you're done, but between 180 to 360 days before you were diagnosed with colorectal cancer, they looked also at the lab tests that had been done. And they found that they were able to identify with their prediction model 10-fold higher risk of undiagnosed colorectal cancer at curable stages, which is huge. If you looked at, they're able to do that 180 to 360 days prior to the clinical diagnosis. And they found that in their model, at a minimum, to make it more effective at predicting, you needed gender and age along with that CBC value. And we know gender and age are already risk factors for colorectal cancer. That's something we do when we take our history when we see patients. So at a minimum, you need those three things, and then your ability to detect this is much higher. This study, this group, Kina and their team, they were interested in trying to figure out, okay, we've created all these prediction models, and there's a lot. When you look at the literature, there's a lot of prediction models, and we tried to do a similar thing in Ghana. There was a recent study that was done in Nigeria where they did a prediction modeling too, where they had people fecal for blood testing get scoped, and then they compared their prediction model to what actually they found. So there's a lot of work around prediction modeling. But this group was like, okay, if we take a model that has been designed in one context, can you apply it to another context? And so they looked at Israelis, about 600,000 Israelis. Of that, 3,000 had colorectal cancer, and they also did it in the UK, where they had about 25,000 patients with 5,000 colorectal cancer. And they found that their model there was no difference depending on which population or nationality. Granted, this is not a sub-Saharan African population, so this is still a high-income country. One of my research focuses, which I'm very fortunate to be partnering with a pathologist around, and then also an oncologist, is trying to figure out, are there things unique about a person's environment which then increases their risk for colorectal cancer? Why are we seeing kids with colorectal cancer in this population? Is it dietary? Is this like environmental exposure? Is this something that's happening that's unique in that space? And that is very similar to what Dr. Lisa Newman did around breast cancer, trying to tease apart, is there something that's going on in the African population, and then comparing it to an African-American population, because we are seeing higher numbers of these in African-American populations here in the US. So is it in our genes, or is there something else that's playing into it? So that's a separate line of work, which I'm not going to discuss today. So most of the prediction tools, if you look at them, seem to do a better job at picking up right colon cancers. And that might be also because in general, these tend to be a little bit more delayed coming to presentation compared to sometimes the left-sided ones, but most prediction tools are better at right. So that's a lot of stuff around in prediction modeling, but it doesn't address the issue with, okay, now you have a CBC. And the reason why we are choosing liquid samples, because the question you might have is, well, don't you still need patients to go to a place and get a lab test done? And someone has to draw the lab and then all of those. So isn't that still an access issue? And that was definitely something that was discussed in the team. What is unique, at least in Kenya and a few of the larger sub-Saharan African countries, that several years ago, in response to HIV/AIDS, a lot of labs were created in communities and villages so that they could have points of contact with folks to test and track disease spikes, and then also to do treatments. And so they have this impressive network of labs that have been repurposed over time to address different things that have come up from a public health standpoint. They have labs in places where they don't even have a doctor or a nurse or a midwife. And so that's how the extent and the reach of this. So the whole thing is we are using that sort of network in order to do blood tests because that's already been set up. Well, then you'd say, well, then why don't you do fecal occult blood test in it? Why don't you just do stool-based test? Why come up with this very fancy system? The issue with fecal occult blood test is that you need to do 3 tests in order to make sure that you improve the sensitivity of it. They have to be done on 3 subsequent days. And then you have dietary restrictions that go along with that. So some foods that you eat create a false positive or false negative. So you have to be able to educate the community around that. And that's an issue. Also, the reagent that you use to do the test has to be stored specially. And then someone has to read the card because the longer it stays, the information disintegrates. So you can't use it. It's not like you can save it and transport it to another center. FIT is the other modality. That's a one-time test. It's more costly. You still have a reagent that needs to be stored, and then you still need to have someone to read a card. So again, not as feasible. The pattern recognition is something that we are working with our experts in the field around. If someone does get a polyp, something biopsy, instead of needing a pathologist, could we use computers so similar to what you use to like open up your iPhone? It's the same that now you can put a phone to your face. My kids are always trying to do that to unlock my phone. They're always trying to get it to recognize my face. But you can do that to pattern recognition in airports for security purposes. So applying that same knowledge when it comes to pathology, tumor sites and stuff. And so we are trying to train machines to do this for us now, such that slides are being sent from Kenya and Ghana here, and then we are trying to train them in order to do this, to get around some of the lack of personnel. So I'm almost done. I want to circle back to the 2 patients I presented. So Mr. AB, I called my research collaborator, which is again, sometimes you never know when you're going to need a friend. So my research collaborator in Kumasi, who had been involved in all this survey, and I said, I have this situation. This gentleman has been to 2 places already in Accra, which is the capital. What next? We need a good surgeon. We need someone to see him. He managed to call a friend at the largest hospital in Ghana. They got him in. They did his surgery. They did a right colectomy. The pathology was a moderately differentiated adenocarcinoma. I've listed out the stage there. It was a T3N0. They looked at 0 out of 4 lymph nodes, and we already knew from the CT scan that he didn't have metastasis. If you're here and you know anything about oncologic resections, we usually say we need about 12 lymph nodes to help guide some of our decisions around what do you do next. He's 80 years old. He's in Ghana. Based on our life expectancy calculations, he's already done really well. Actually, when you turn 70, there's a huge party they do in Ghana because you've made it longer than the predicted time. When you turn 80, it's almost like a golden jubilee. I mean, it's huge, the kind of party, because you lived longer than you were expected to. So he's 80. No one's going to give him chemotherapy. But it's interesting because they had 15 lymph nodes actually retrieved. The pathologist looked at only 4. We asked the pathologist, why did you look at only 4? He's like, if you look at his caseload that he needs to do, he doesn't have the time to spend on an 80-year-old, even though the surgeon took out the lymph nodes. This Mr. AB, this is day 1 after his surgery. I can tell he's not using a wheelchair anymore. He's overall healthy. Expect that he'll live long, but doing really well. And I can tell you every month I get a message from him or his family just saying thank you. And I don't do it for that, but it's just amazing to see the difference between if you can get someone the right care, the difference it can make. Next, XY, I highlight 2022. Remember, I got that WhatsApp message in 2020. So it took us 2 years. She finally went to the UK to get her care after her family managed to get money. They did another scope. There was no polyps 30 centimeters from the anal verge. The transverse colon had the polyps that are indicated there. There was a 30 millimeter polypoid tumor in the cecum, and there was a 5.5 centimeter cecal mass with concerning lymph nodes on the CT scan that they did. She had her surgery last week. She got a right colectomy. They are planning on doing an endoscopic colopectomy post-op because she was so symptomatic. They decided to do surgery up front and then get a GI doctor to do an EMR for the other sides. And we're waiting her path results. So colorectal cancer screening. I would challenge us all, especially those of us engaged in global health spaces. It's not just enough to take, again, wholesale what we do here in the US and apply it in places without, again, taking into account the local context. If we are going to do a policy, then it has to be one that we disseminate appropriately. It's not enough to have a document that you give to the Ministry of Health or whoever you're working with. There has to be some intentionality around that. And then how do we get patients there? My group, I'm fortunate to be working with this group, and we're looking at other channels. How do we use machine learning? How do we use pattern recognition to get around the provider issue? And then looking at liquid biopsy as a potential option. We don't know if this is going to be the answer, but at least we are willing to think outside the box. And coming soon, I'm pretty excited about this. And this has been over several years. I can tell you it helps address my issue of my brain drain guilt. But being able to create what would be the first colorectal surgery fellowship program in Ghana. And this is going to service the entire of West Africa. So we just got the curriculum completed. And this is using a lot of collaborations done in Ghana, but also having some great mentors up here who have helped me think about this. We've passed 3 levels. We've passed the first level of approval from the government standpoint, and then hopefully this is getting rolled out next year. So I do want to say thank you. I always feel terrible when I forget to list particular individuals. If I miss someone, I feel so bad about it. So instead, I'm going to use these general things, but I have such a wonderful team in Ghana who have been committed to working on this, especially the surgeons and the GI doctors. I can't tell you how frustrating it is for them to have been trained in certain skill set and not have the resources to be able to do that or be limited in other ways. The GI providers, especially when they say they can't take out polyps, they can't biopsy stuff because the patients can't afford it. It really weighs on them. And so there's been a very committed group here. There's a group in Kenya, equally passionate, and we've been doing some great work there. And I have a very dedicated group of students, residents, faculty here in the US across different institutions that have been helping us. And I do want to say thank you to all of you.